Definition. Complete atrioventricular (AV) block is defined as the inability of an atrial impulse to be conducted to the ventricle. Second-degree AV block occurs with progressive slowing of AV conduction, progressive PR prolongation, and eventual loss of conduction, P wave with no QRS complex. Second-degree AV block may be labeled Mobitz type I or Wenckebach block. Block occurs in the AV node proximally after progressive slowing of AV conduction evidenced by PR prolongation until conduction is completely blocked. Mobitz type II AV block occurs in the His bundle with either relatively normal conduction or AV block, more commonly progresses to complete AV block. First-degree AV block results in delayed conduction from the atrium to ventricle, with a prolonged PR interval, but no loss of conduction, see figure. Symptoms. First-degree AV block, patients are usually asymptomatic. Second-degree AV block, patients are only symptomatic if block results in a long pause, greater than 2 to 3 seconds. This is seen only in high-grade AV block. Third-degree or complete AV block. Dizziness, presyncope. Syncope, sad face secondary to low cardiac output and hypotension, fatigue. Exercise intolerance, secondary to blunted cardiac output response to exercise, limited by inability to increase heart rate normally. Sudden death, prolonged pauses or acetol lead to ventricular fibrillation or cardiac standstill. Signs. First degree, none. Second degree, in Mobitz type I, irregular pulse with pauses. In Mobitz type II, irregular pulse with occasional dropped complexes, bradycardia, signs of congestive heart failure, tachypnea, retractions, rales, hepatomegaly, jugular venous distension, edema. Third degree, bradycardia, signs of congestive heart failure, tachypnea, retractions, rales, hepatomegaly, jugular venous distension, Cannon waves. Edema, high drops in the fetus. Investigations. Complete AV block is associated with congenital heart disease, most commonly L transposition of the great arteries, ventricular inversion or corrected transposition, or heterotaxy syndromes. These defects can be identified by cardiac ultrasound, ECG, to evaluate degree of block and location of escape rhythm. Block in the AV node usually results in a narrow QRS escape complex. Block in the His, Purkinje system may result in a wide QRS escape complex. 24-hour ambulatory monitoring, Holter to evaluate extent of AV block. Second-degree AV block is common in adolescents during sleep and is usually benign unless pauses are excessively long, greater than 3 to 4 seconds, or block is high-grade. With complete AV block, the low rate should be noted as well as pauses greater than 3 seconds, ventricular ectopy, and prolongation of the QT interval, all of which are associated with increased incidence of syncope and sudden death. Differential diagnosis. Diagnosis is made by ECG. Care should be taken to distinguish AV dissociation with accelerated junctional rhythm or sinus slowing from AV block. Differential is in determining etiology, treatment, diet and lifestyle. No dietary restrictions. For first and second degree AV block, that is asymptomatic, restrictions depend on underlying cause. Those patients with myocarditis or inflammatory heart disease should restrain from vigorous activity. Patients with complete heart block may be allowed to set their own level of activity. Excessive fatigue or exercise limitation may be an indication for pacemaker implantation. Pacemaker implantation may result in restriction from contact sports, including wrestling and football. Location of the pacemaker. Chest or abdomen may result in additional limitation. Pharmacologic treatment. Acute treatment. Standard dosage atropine, IV bolus, 0.02 to 0.04 mg/kg, maximum, 1 to 2 mg. Contraindications: hypersensitivity to anticholinergic drugs, narrow angle, glaucoma, tachycardia, myocardial ischemia, obstructive gastrointestinal disease, obstructive uropathy, myasthenia gravis. Special points: lessens AV block when increased vagal tone is a major contributor. Can be given every 1 to 2 h. Main drug interactions: amantadine increases anticholinergic side effects. Atenolol increases blockade effects, phenothiazines. Decrease antipsychotic effects, tricyclic antidepressants. Increase anticholinergic effects. Main side effects: gastrointestinal, altered taste, nausea, vomiting, constipation. Dry mouth, genitourinary, urinary retention. Ocular, blurred vision, dilated pupils, increased intraocular pressure, cardiovascular, palpitations. Tachycardia, central nervous system, headaches, flushing. Nervousness, restlessness, other, decreased sweating. Standard treatment. Standard dosage isoproterenol, 0.1 to 2.0 g/kg/min IV. Contraindications: relative, pre-existing ventricular arrhythmias. Elevation of heart rate may suppress ventricular ectopy. Special points should be used as a temporary bridge until temporary or permanent pacing can be achieved. Main drug interactions: use with other sympathomimetic bronchodilators or epinephrine may result in exaggerated sympathetic response. Effects of isoproterenol in patients on monoamine oxidase inhibitors or tricyclic antidepressants may be potentiated. Blocking agents and isoproterenol inhibit the effects of each other. Main side effects: central nervous system, nervousness, headache, dizziness, weakness, gastrointestinal, nausea, vomiting. Cardiovascular, tachycardia, palpitations, chest pain. Other, flushing, tremor, sweating. There are no effective drugs for chronic AV. Other treatment options: temporary pacemaker used in emergent situations until more permanent pacing can be achieved, or in situations deemed to be temporary, myocarditis. Drug toxicity. Treatment aims to return patient to normal activity and normal life, to prevent syncope and sudden death. Prognosis. Incidence of sudden death in postoperative complete heart block that is not paced is as high as 50%. In congenital heart block, incidence of sudden death is 5% to 10%. Prognosis is excellent in both groups once pacer is implanted. A small number of congenital heart block patients develop a dilated cardiomyopathy. The prognosis in postoperative heart block is related to the underlying congenital heart defect and any residual lesions. Follow-up and management. Patients with first and second degree AV block should be followed at least yearly to observe for the development of higher grade or complete AV block. Patients with a pacemaker need monthly to bi-monthly transtelephonic checks and twice yearly office checks with complete analysis of the pacemaker function. Permanent pacemaker generators require replacement every 5 to 15 y. Wires may fracture or require replacement secondary to growth when placed in a small child.